our Clinical Audit Awareness Week. It's day 4 today. And we've a of Lightening Talks with some of our National Clinical Audit Leads. And we're delighted to welcome Dr. Orla Healy, who's going to open our session this afternoon. So in the interest of good timekeeping and on behalf of the wider National Clinical Audit team, I'm going to hand over to Orla.
Thank you very much, Karen. Good afternoon and welcome. I'm delighted to join you this afternoon, right in the middle of our Clinical Audit Awareness Week. This week, as you know, is an opportunity to learn more about audit in general, clinical audit that is, and how you can undertake clinical audits in your services. The theme of this year's HSE Clinical Audit Awareness Week is Clinical Audit, Humans and AI Smarter Together. So this year, we've introduced these lightning talks as part of our events taking place during the week. I'm sure many of you will have had an opportunity to listen to the webinar on the same theme earlier, but this particular lightning talk is being hosted by ourselves in the National Centre for Clinical Audit to give you the opportunity to hear from our own colleagues who are leading out on a number of our own national clinical audits. So our panelists today include Dr. Nigel Salter, who's the National In-Hospital Cardiac Arrest Audit Lead, and Alison Bone, Patient Safety Strategy Improvement Coordinator in HSE Dublin and South East. We're also joined, I hope, by Dr. Robert Briggs, who's leading out on the National Falls audit, Dr. Michael O'Dwyer, who's the National Sepsis Audit Lead, and Karen Davis Holden, who's a sepsis ADON in Dublin Midlands, and Nuala Clarke, who's the Group Sepsis Lead and ADON in CHI. And Karen, you've already met, is our Clinical Audit Governance Manager in the National Centre for Clinical Audit, and she's hosting and leading the session. The panellists will each present the findings of their audits to date and also discuss the enablers and the challenges which help us to identify areas for improvement. They will each explore how to use the findings to inform an action plan and to make meaningful improvements to support and build a culture of quality improvement within audit cycles. And all of this helps to build a supportive, enabling culture for clinical audit, for quality improvement, and for wider patient safety. So I'm looking forward to the talks, and I hope that you too are looking forward to them and that you'll find them both useful and enjoyable. So over to you, and thank you very much.
Thank you, Orla. Thank you. So great. So before we hand over to the National Clinical Audit Leads, on behalf of the National Centre for Clinical Audit team, I'm just going to take you through a few high-level slides in terms of just so we can just give you some updates. Now, for some reason, okay. So for those of you not aware of who we are, where we sit, I'm just going to keep this very, very high level. The National Centre for Clinical Audit here in the HSE was established following the National Review of Clinical Audit in 2019. So our programme of work over the last 3 years into the 4th year has been mainly under 5 strategic pillars, and they are the national governance of clinical audit, the local governance of clinical audit, the whole area of clinical audit education and training, and clinical audit resources, and then legislative issues affecting clinical audit, such as GDPR and more recently the Patient Safety Act. So, for example, all of the national clinical audits that you're going to hear updates on today are one of many national clinical audits that have been approved via the HSE National Steering Group for Clinical Audit. So, in tandem with good governance and good project management, each of the national clinical audits then would have their own steering group in situ and their own working group. And the presenters today are audit leads across the audit programmes. So as part of the wider National Clinical Audit Awareness Week, which has been celebrated here in Ireland and indeed beyond with our colleagues over in the UK and even Europe, we've had a really exciting lineup of events throughout the week. So recordings from our recent QI talk time, which was Humans and AI, really good session, has been recorded and will be made available at a later date. Similarly, yesterday we had a really good clinic with QA with our colleagues from CASC in the UK, Tracy and Stephen. So that was also recorded and we will make those available at a later date. So tomorrow's lineup then is local clinical audit presentations, and there is still time to register for that. And you'll see the QR code there, or you'll find the QR code on our website. So I'd like to signpost you to some of our recent publications and initiatives. So what's gone live recently, for those that are not aware, is our brand new clinical audit portal, and it is accessible on the NCCA website. So there you will find all things clinical audit. So it's the really go-to place to find what you're looking for in terms of up-to-date templates, policies and procedures, publications, and lots of growing material for clinical audit. So do have a look. You'll see the QR code there. We will be doing a more deeper dive in terms of a QI talk time, hopefully in the autumn, and we will cover the functionality of the clinical audit portal then. But for now, do have a look and let us know what you think of it when you get a chance to test it. Some updates in terms of our published resources for clinical audit. So hot off the press is our revised clinical audit practical guide. It's just the revised publication has just been published there in May. And this latest guidance will help you understand the clinical audit criteria, particularly with the addition of the Patient Safety Act and the changes. It's got enhanced updates for data protection and GDPR considerations. And similarly, our nomenclature, which is our glossary of terms for clinical audit, has also had an update and published just there in April. So within our nomenclature, you will find a comprehensive list of 14 definitions for all things clinical audit. And one of the most common questions that we're often asked here is, what is the difference between clinical audit and research and service evaluation? So we have a lovely table in our nomenclature which answers exactly that. It goes through the differences in terms of methodology, function, and everything to do with definitions in that genre. We also have a range of supports for local clinical audit toolkit, and recently we have a functional Excel template to help you with data analysis, particularly with those audits at local level. And we're always delighted to get feedback from people who are using the resources, and that is how we can retrospectively then grow them with future updates taking into account your feedback. Our clinical audit training and education sessions, they happen right throughout the year. So I know many of you online today will have attended some of our clinical audit training. So we do have our e-learning, which is available via HC Land. That is available to register and you can access it 24/7. We then have some in-person virtual training events, and our next session in fundamentals in clinical audit is actually next week on the 11th of June. So booking is still open for that. And then for more advanced practitioners in clinical audit, we have an advanced training course in partnership with the Clinical Audit Support Centre in the UK, and that is happening on the 25th of September. And new for this year, what we've introduced is the concept of clinical audit action hours, which is basically a go-to event where you can come ask your questions and answers, or a deep dive into some specific topics. So our next session in September is looking at smart sampling for clinical audit, which is really exciting. For those of you not familiar with the Clinical Audit Network in Ireland, we have recently re-established it, and it is primarily there for peer support to share best practice. And our next meeting is the 11th of June, and we will be looking at clinical audit and incident management, the correlation there. Our aim is to grow this network. And for those of you who would like to become part of the network or think that your post aligns itself nicely to it, do email us at ncca@hsc, and we would gladly give you further information. So as I just said, we have an exciting lineup right throughout the week. Tomorrow's event is still open. And as you can see here, we've had a lot of submissions for the local clinical audit presentations, and it was really difficult to select 4. However, we've tried to do a nice mix in terms of clinical topics and geography. So we've 4 exciting lineups scheduled for tomorrow. So as I said, booking is still open for tomorrow's event, which will happen from 12 to 1. And in the interest of good timekeeping, I'm going to keep it very, very tight and wrap up. So as always, further information is available by emailing us or checking out our website. So at this stage, I'm going to hand over to my colleagues from the National Cardiac Arrest Audit, and that is Dr. Nigel and Alison Bone, and I'll let them introduce themselves. Thank you.
Thanks, Karen. I'm just going to share our presentation. You can let me know if that's displaying okay.
Yeah, all good.
Great.
Perfect.
Thanks, Karen.
Great. Thank you. Good afternoon, everybody. And as I was driving into work this morning, I suppose it feels like we're reminded on a nearly daily basis of the importance, when we talk about human factors and AI, the importance of having systems in our healthcare organizations through media, through social media, through HICWA reports, through coroner's inquests, through litigation, focusing on our deteriorating patients, and I suppose in particular those who may have avoidable deterioration or unexpected deterioration on our wards. And we have, over the last 10, 15 years, there's been a lot of, I suppose, improvement strategies been implemented through things like the early warning systems from the National Clinical Effectiveness Committee, iNews and iMuse, amongst many others, as well as our critical care outreach teams, medical emergency teams. But in many ways, we sort of have the cart before the horse in that we've implemented improvement strategies, but without necessarily having outcome metrics to assess their effectiveness and if they're achieving what it is we need them to achieve. And I suppose we'd like to share with you our journey in relation to that, our participation of our hospitals in our region in the National Cardiac Arrest Audit. So the National Cardiac Arrest Audit, to give you its background, was basically established as a project in the UK whereby hospitals from the UK and Northern Ireland can compare audit data in relation to in-hospital cardiac arrest. And it's a collaborative project between the UK Resuscitation Council and a group called ICNARC, the ICU National Audit and Research Centre there. And this is the first time we've had an opportunity for a group of hospitals from the Republic of Ireland to be able to participate in this audit and to allow us to collect validated data around cardiac arrest for our region. So to give the context of I suppose what standards there are, there's an international liaison committee on resuscitation, and they have given recommendations for audit, but also for quality improvement around in-hospital cardiac arrest, which is represented on the graphic on the left of this slide. And I guess it's to that end, it's going back nearly 20 years ago to the publication of the National Sudden Cardiac Death Task Force report, where amongst their recommendations was that we should be recording data. There should be some form of at least register, if not audit, for both in-hospital and out-of-hospital cardiac arrests. And on foot of that, OCAR, the out-of-hospital cardiac arrest register, evolved, and a huge credit to the Pre-Hospital Emergency Care Council here in Ireland. They've been an outstanding quality improvement system and a leader throughout Europe and internationally in this area. The achievements that they've been able to deliver in terms of bystander CPR engagement and making sure that people have access to AED devices in the community is phenomenal, a phenomenal achievement, and they're still ongoing with that. And I suppose it's been a real inspiration for us in terms of what we can hopefully try to achieve with our in-hospital cardiac arrest metrics. Sadly, we've been lagging behind up until now, and it's harder as hospitals to be able to coordinate what we're doing. But a lot of the credit to this has to go to our resuscitation training officers nationally. A group called the Irish Association of Resuscitation Officers published a survey of their members, which found that they were actually collecting a lot of data around cardiac arrest. But what was variable was how they were collecting the data, what exact data they were collecting, and there was no real standard system for either being able to report that data, for governance structures for that data, or indeed to deliver on quality improvement in it. We might go on to the next slide there, please, Ali. So part of that process, we were granted funding thanks to Dr. Healy from the National Quality and Patient Safety Directorate for a group of hospitals from the Dublin South East region to be able to enroll into the National Cardiac Arrest Audit. And part of that was that we needed to set up a governance structure. And I suppose that was about looking at leadership, looking at teamwork, looking at communication, and engaging appropriate stakeholders, both from individual hospitals and regionally, so that this wasn't just data that sat on a shelf, that it was data that we could meaningfully share, look at and analyse from a QI point of view as a region. Ali, I might hand over to you for the next slide, please.
No problem. Thank you, Nigel. So I'm going to delve a little bit more deeply into our findings, our data set, and how we proceeded with the audit, which we don't have the final reports on yet, but I'll talk to that. So just in relation to the events and the cardiac arrest patients that were included in our audit, so the scope for inclusion was any patient that was aged over 28 days and any resuscitation event that commenced in the hospital where the individual received chest compressions and or defib and was attended by a hospital-based resuscitation team. And the domains, there were 20 data points collected for the audit, as well as the total number of admissions per month and the total number of cardiac arrest events. The domains for the data, and they're based, as Nigel had mentioned, about ILCOR and their recommendation about what is collected. The domains for the data covered the hospital, the patient, the pre-event, the cardiac arrest process, the post-resuscitation process, and the outcomes. The data set for 2025 that commenced on the 1st of April actually has additional inclusions, and they consider the patient frailty as well as more around the clinical interventions. And just to clarify, if a patient achieved return of spontaneous circulation for greater than 20 minutes and then rearrested, that is included as an additional event, and we had one patient that fit that criteria. Standardized data, Nigel has kind of referenced, and there is a standardized data collection tool that's provided by the National Cardiac Arrest Audit Team, and that's used by all participating sites and facilitates our benchmarking against all hospitals that are participating. For the purpose of our audit, we commenced our data collection at the 1st of April 2024, and we finished our data collection for the purpose of this pilot at the end of March. We did make 2 amendments to that data collection tool, and this was one of our challenges, I suppose, around GDPR and potential risks with GDPR issues when we're putting patient information onto a portal in the UK. So we did remove the date of birth, but the age of the patient remained, and each site created a unique patient identifier, which was case sensitive, and that mitigated against the risk of having to put up the hospital number. So effectively, no specific patient identifiers were used at all. So we had 9 hospitals that participated. 3 of those hospitals joined for 3/4 of the year. And that was because when we commenced the audit, we overlapped with the restructuring into the new health regions. That we also had to make additional considerations at that time for the governance of the audits for those hospitals that had left what was the Ireland East Hospital Group and sat within the newer regions. And it didn't stop us in this process, and those sites remained on board, which was great. The reports are published quarterly to each site, directly to each site from the National Centre for Clinical Audit. They're cumulative, and they're provided once a site has a total of 5 events. So some sites haven't had 5 events, but all sites will receive an end of year report, and they're due out this month. For anyone that's familiar with the Irish National Intensive Care Unit audit, the audit reports are very similar, and I've just given you just a sample of how some of the findings are displayed within the audit reports. And what was really significant finding for us was that none of the hospitals had any results that sat outside of the expected ranges. And actually our findings were probably more favourable than those that were estimated in the literature for in-hospital cardiac arrest rates and survival rates within the Irish setting. So actually our findings were really positive. Okay, so just drilling down a little bit more into the results. So each hospital does receive their own results, but for the purpose of this presentation today, we've amalgamated all the reports into one cumulative report. At the top of the screen, you'll see displayed a reference to team visit record, and a team visit record is a term that's used in the National Centre for Clinical, confusing, NCCA and NCCA, in the National Cardiac Arrest Audit. That's the term that's used for each eligible cardiac arrest event. Data completeness was a challenge. It's also a challenge in the UK, and that required regular follow-up by our data collectors who absolutely worked meticulously ensuring that all of the data was complete and it was all received relevant to the eligible patients. This was an additional task that was undertaken by the data collectors on all sites, of which we're hugely appreciative of, but we see that a dedicated resource would really enable and facilitate this process to help and drive and address this challenge should this audit be engaged at a national level. So this is a cumulative overview of the 5 hospital reports that we've received to date. 2 of those hospitals commenced their data collection in Q2 for the challenges that I've referenced earlier on. So from a demographic perspective, we can see that 63.9% of the eligible patients that were included were male. From an ethnic perspective, most of our patients were captured as being white Irish, 95.2%. We do see this as an area of improvement. From our patient perspective, there is some variation in regarding ethnicity and whether we're asking the question, and on the vast majority of our healthcare records not specified as selected. So we do see this as an area for improvement. The mean age range, the mean age of all our patients is documented in the reports, and the mean age range across our hospitals that were included ranged from 67.9 years to 75.4 years, and the majority of our patients sat within the 75 to 84-year-old category. We had no patients included that were less than 16 years. The reason for attendance is captured, and the majority of our patients sat under the medical service, and the majority of our arrests happened in an in-hospital location, and an in-hospital location includes the ward and clinical locations. So our results in our reports are split into the overall number of cardiac arrest events, and they're also provided for the number of cardiac arrest events happening in the ward locations. So our findings were we had 86 cardiac arrest events, which included 85 patients. And our rate of cardiac arrest cumulatively for all of those 5 reports was 0.74 per 1,000 hospital admissions. The rate of cardiac arrest per site ranged from 0.35 to 1.06 per 1,000 hospital admissions. The observed percentage of return of spontaneous circulation sustained for greater than 20 minutes across the 5 sites was 55.4%, or 46 patients, and the observed percentage survival to hospital discharge was 16.9%, total of 14 patients. The modified ranking scale is collated as an outcome measure in the audit, and that's a scale that's used to assess the degree of neurological disability. We did find that for the majority of our patients, there was no evidence in the healthcare record to say that this was assessed. And again, we see this as a potential area of quality improvement in relation to the outcome for the neurological outcome for our patients that survive. The report does provide the median time for the duration of resuscitation for those patients that achieved return of spontaneous circulation. And for those patients that did achieve ROSC, the median time ranged from between 4 and 16 minutes. And for those patients that died, the duration of resuscitation median time ranged between 20 and 40 minutes. From a DNA CPR status, that is collated for those patients that have survived. And we do note that 18 of the 46 patients that survived had a DNA CPR put in place after they had achieved ROSC. And again, this does warrant a further deep dive to look at these patients to see if it was appropriate that perhaps a DNA CPR may have been considered before the event. For most of our events, when the team arrived, the resuscitation was ongoing, or the patient was deteriorating and had not yet arrested. And for the majority of patients, the reason the resuscitation stopped was because the patient didn't achieve ROSC, or they achieved ROSC but for less than 20 minutes. So this is a breakdown of the presenting rhythm into shockable or non-shockable and the survival of the patients to hospital discharge. So 25.6% of the patients, or 22, had a shockable rhythm, and 61 patients presented with a non-shockable rhythm. We had 3 patients whose rhythm was either unknown or not determined. The outcome for those patients, of the 22 that presented with a shockable rhythm, 7, or 31.8%, survived to hospital discharge, and of the 61 with a non-shockable rhythm, 5 patients, or 8.2%, survived to hospital discharge, and 2 of the patients whose rhythm was unknown survived to hospital discharge. On the right-hand side there is a trend graph of the overall 28-day survival, where we can see that 26 of the patients that achieved ROSC greater than 20 minutes were still alive at 24 hours, but 14 of those patients, one patient we couldn't account for, so we have 13 patients there who had a overall 28 days survival. One patient was transferred to another hospital, so we were unable to follow up. So for the purpose of this presentation, we were asked to consider the use of AI in our audit and how it may be used in conjunction with this audit. We know that in Ireland, AI is being used in conjunction with humans in some clinical settings with very positive findings. We did look into the literature internationally specific to in-hospital cardiac arrest, and there is some focus internationally around the use of AI. So focusing on integrated machine learning networks for prediction, analysis and the management of cardiac arrest. There's literature around the analysis of the ECG and the use of algorithms to predict patients that are at risk of progressing to cardiac arrest, and identifying patients that may go into a pulseless electrical activity as opposed to ventricular fibrillation. And for any of my colleagues that are listening here, they're going to think, what on earth is Ali talking about AI? Because this certainly is not an area of comfort for me. But I think it's really exciting, and I can really see the value of AI that in conjunction with humans that can guide us in relation to in-hospital cardiac, and particularly in the use of machine learning. So where computers are learning from our data, and advanced analytics, where we could potentially identify applicable quality improvements based on our data findings. But we need to collect the data, and we need to have collected data over a greater period of time to optimise this opportunity. And I'm going to hand back over to Nigel now just to close out.
Thanks, Ali.
Thanks, Nigel.
I'm conscious of time. I do just want to briefly acknowledge a huge amount of people have been involved over the years of this project, but I do want to acknowledge the support from Dr. Healy and the National Quality Patient Safety Group, as well as the NCCA. It is very confusing, NCAA and NCCA, but also our colleagues Nick Nark, and in particular all our resuscitation training officers and our local data collectors, who really were the drivers of this project and really own this quality improvement project. I suppose this is a pilot. It's a 12-month pilot, and our recommendations are that this is something that is now practical and possible to do, and we would suggest its implementation nationally across all acute hospitals, certainly for Model 3 and 4 organisations, and as an opt-in for Model 2 hospitals to help them to establish benchmarks and to look at a system for collecting data around cardiac arrest. There is a piece of work in with regards to, we have identified there are some resource gaps that need to be addressed for audit locally as well as regionally, and we would support the involvement of PPI with regards to a framework for this nationally. So very finally then, we've talked about, we've established a baseline rate of cardiac arrest in our region for the first time in Ireland, and a really positive rate of survival to hospital discharge, which is to be honest, much higher than I expected it to be. And I think as a quality assurance metric, this is a really promising prospect for us as we face the challenges of patient deterioration and improvement of that on our wards. And in the interest of time, we might wrap up there. Thank you.
Thank you so much, Nigel and Ali and the wider teams across the hospital sites. That has been really, really insightful. So in the interest of time, we will take questions at the end. So Karen and Nuala. Great. So we have slight little change in our schedule. So we're going to take the National Clinical Programmes update on sepsis. So I'm going to hand you over to our colleagues Nuala Clarke and Karen Davis Holden. And I also acknowledge Dr. Michael O'Dwyer, the clinical lead, I think is also in attendance here this afternoon. So everybody is very welcome. So I'll hand over to the team there. Thank you.
Great. Thanks very much indeed. Can you hear me there?
Yeah. All good.
Perfect. Perfect. My name is Nuala, and as you say, I'm a sepsis ADON, as is Karen, my colleague here beside me. And we both are members of the sepsis team, and we're project leads on this project. So I suppose just to give you a background to the National Sepsis Programme, it evolved on the back of a HICRA report on the death of Sunita Halappanavar, and the National Sepsis Programme was born in 2013. The first guideline published in 2014, and we implemented that over the year of 2015. And from then onwards, we have a trajectory where we have been updating our guidelines. We launched an e-learning programme in 2016. We produced, for the first time, we produced a paediatric guideline in 2021 and updated the National Clinical Guideline at that time also. And we're now currently at a rapid update session for the guideline for 2025. And that will include a new sepsis form for both maternity and adult patients. Apologies, my little fella's moving great. Great. So how we monitor as a programme, we do it in two ways. One is we produce an annual audit of outcomes resulting from the implementation of the National Clinical Guideline. And really this is kind of giving us quite crude mortality data, because it's based on inpatients in publicly funded hospitals with the diagnosis of sepsis that's coded on the HYPE system. And so we'd be the first to highlight that causality can't be inferred, I should say. Sepsis is one of the many diagnoses that complicate the patient's admission, and our mortality rates are sepsis associated and include direct and indirect causes of death. The other method of audit that we have currently been doing, and why we reached out to the NCCA to improve our processes, was we produced an annual audit for the implementation of the National Clinical Guideline. So this was really a process audit that we performed in all our hospitals for all patients, for adult, maternity and children. And so every year we would annually retrospectively audit a snapshot of patients on each site, generate a report, develop an action plan as agreed by our in-hospital local sepsis or deterioration patient committees, and then look to see could we improve and re-audit and see could we see local improvements. And I suppose looking at the NCCA descriptor there, that's exactly what we were trying to do, improve patient care by systematically reviewing it against our explicit sepsis guidelines. We also support local audit, and we have a lot of local audits ongoing on the back of our QIs in pockets across the country. But I suppose where we felt there was a requirement or a need was that we were a team of 7 sepsis ADONs going out to all sites doing these audits on a continuous basis using a standardized Excel audit tool. And whilst we produced good results and we produced good reports, it was still remained quite a local process. And what we wanted NCCA, and when we reached out to them last year, it was so that we could upscale and aggregate and get some national data. And we were very grateful for their support. I think what we really were hoping for was that we could improve the information we were gathering on our national reports to kind of identify things like regional variations, just, I suppose, the patient's journey of care and where we could improve on our ability to identify a deterioration patient earlier and improve that process. So when we reached out to NCCA, they embraced us and we were very grateful for it, giving us their clinical audit expertise. And we set up, and I'll show you in the next slide, the process that it took, and it was quite a sizable piece of work, and it couldn't have been achieved without the input from a lot of expertise. There was a huge piece around information governance. I can say things like DPIAs and DSAs now as if I know what I'm talking about, but I must say it was like Swahili at the beginning, and I had the likes of Nigel who took ownership of all that piece, and that was a big piece of work trying to get just our GDPR piece in aligned, making sure that our national data protection officer was involved, getting our DSAs, so our data sharing agreements among all our sites, so that we could aggregate the data and report it. They provided us with project leadership, so we had Alison, one of the team, who managed us very well, so well that we didn't know we were managed. So that's always a sign of a good manager. And she was kind of keeping us to task and making sure we stayed on cue with all of the jobs. And we reached out to NOCA, who came on our support group to support us. And again, they were really useful in helping us trying to define our methodologies, trying to get us to develop our data sets, and prompting us to look at things like outcome measures and the like. And then also the NCCA provided a link between the IT system, which was Meg IT, and ourselves. So we had somebody that was liaising between the two, which was very useful. So really, this is just a snapshot of the methodology. I'm not going to read it all, but we started in February 24, we finished in February 25, and it seems like an inordinate amount of time, but each phase took longer than we'd anticipated. Certainly the DSAs and the DPIAs, caused us a little bit more of time that we didn't anticipate at the beginning. And we were anxious to try and get auditing, as you can imagine, because we audited every year. And so by the time we got this over the line, we were auditing late of 2024. And we had to develop 3 tools. We had to test it, we had to analyze it, we had to work with the teams to make sure that the data we were producing was representative of what we needed it to show us. So I'm going to hand over to Karen now.
So in September of 2024, the National Sepsis Programme actually introduced key quality indicators, and these were founded on the audit findings that were consistent since 2018. And there were identified areas for improvement, particularly around the use of the sepsis form and the elements of the sepsis 6 bundle, and basically they would be blood cultures and urine assessment and measurement, and the provision of or the administration of antimicrobials within 1 hour, or in paediatrics it could be within 1 hour or 3 hour period. These KQIs were actually aligned with both the adult and the paediatric National Clinical Guidelines. Now, the outcome after 30 days was actually a suggestion from NOCA. So this was a question that was added it went into our in our audit for those patients that were confirmed sepsis or septic shock, and where they were at 30 days of their treatment care and their care plan. The outputs, as Nuala has explained there, we basically, the National Sepsis Programme and NCCA with their advisement, we basically, we agreed the audit data set, and they were all developed then onto Meg IT, and that comprised of testing and re-evaluating the audit data set. However, when we introduced the KQIs, then we had to make amendments to the data sets of both the paediatric and the maternity audit tools. In relation to Meg and itself, the ADONs only have access to their own data within their own region. And when they complete an audit, they will then update the audit results into Meg, so they will, and they will use the dashboard. It's in real time. They use the dashboard then to complete audit reports, and that are given to the individual hospitals, and then are disseminated via their local governance structure. And that local governance structure, but local, regional and national governance structure is in the onion there on the right hand side. Simultaneously, the programme manager and Michael O'Dwyer, the clinical lead for the National Sepsis Programme, had an overview of all the data from all sites, regions, and following the completion of the necessary steps to meet the information governance requirements, the first aggregated regional report of high-level KQIs was issued to the REOs of each regional health authority in April 2025. Now, this is a cumulative report of adult data from to 2024, and we basically audited approximately 400 persons, and of those, 87% of those patients were appropriately screened for sepsis. That means that that there's 13% that basically they should have gone down to sepsis pathway, but they went down it later than anticipated. 17% of those cases had their sepsis forms fully completed. This would include a diagnosis with a doctor's signature, and this actually helps the HYPE coders code the patients correctly as sepsis septic shock. Of the Take 3, Give 3, 75% of patients received elements of Take 3. So those elements would include blood cultures, bloods, a venous lactate and urine assessment and measurement. And then 82% of those patients received the Give 3. And again, that would include the first dose of IV antibiotics, IV fluids and oxygen within 1 hour of time zero. However, the 30% of those audited had received the Sepsis 6 bundle in totality within 1 hour of time zero. Sorry. The recommendations and improvements, the recommendations that were in the REO reports that were sent to each of the regional health authorities outlined the following, and the key would be the utilisation and completion of the sepsis form. This is to improve early recognition, escalation and management of sepsis cases. And it also included the administration of antibiotics, the documentation of urine assessment and measurement. All relevant staff should complete sepsis e-learning on HSC land. So we've got 2 programs on HSC land, and this should be monitored locally. And we also advised that local education on sepsis should include simulation training, based training. Another recommendation was that we advocate that sepsis diagnosis should be included on the GP summary to ensure patients can access post-sepsis care if required. The SWOT are the challenges, and again, the SWOT analysis highlights the strengths, the opportunities, the weaknesses, and the threats we encountered. Some strengths included the utilisation and the expertise of the key stakeholders from both NCCA and NOCA, who helped develop the sepsis audit tool, the development of the KQIs, and aggregating the data nationally for the first time. The National Sepsis Programme reviewed the 3 audit methodologies and gave us an opportunity to collaborate with the Health Price Office to tighten and strengthen our search criteria for audit to identify the patients to be included in the audit. It also allowed us to standardise our audit reports locally and regionally. The threats to the project included that we needed to future-proof the audit tool so that it's going to align with the upcoming sepsis management rapid update. And another challenge that we actually identified would be to actually upskill this audit for every patient to be audited, which would be approximately 15,000 cases per annum. This would take an awful lot of personnel and resources to achieve that. We also identified that because we're not very good at documenting sepsis and septic shock, there is poor coding of both, and this remains a problem. And a weakness for us then was that when NCCA handed over the baby to us and stepped away, This meant that 2 people had to be identified within an already saturated team to oversee MEG IT. The key learnings for us from this is nationally and internationally, we know that 80% of sepsis cases present via the ED department. And our audit actually highlighted that 57% of patients presented via the ED. And as a result of that, we've actually introduced local ED audits within our many of our regions. So we have. The audit also showed that there was a 30% compliance to the delivery of Sepsis 6 bundle within 1 hour, and highlights the importance of utilising and completing the sepsis form. As recommended by by NOCA, we captured the 30-day outcome of the patients within the audit, and we learned 15% of patients are still in hospital at 30 days. 44% of the patients were actually discharged home at 30 days, and 13% were either discharged to residential or step-down facilities. Unfortunately, 8% were recorded as unknown because they were transferred to a higher level of care. In line with national and international crude mortality rates, our audit actually reported that 19% of the patients audited died from sepsis or septic shock. We just want to say a huge thank you to NCCA, Nigel, Alison and Celine. Without their support, I don't think we would have got this project over the line as quickly as we did, even though it took a year. And Marina Cronin from NOCA for her input, and of course the provision of funding and support from our Quality Patient Safety Directorate. Thanks very much.
Great. Thank you very much, Nuala and Karen, and indeed Michael there in the background and the wider team. So I'm going to hand over to my colleague, Dr. Rob Briggs, on behalf of the National Falls Audit. So hopefully technology will oblige this time around. So Rob, I'll hand over to you there for the slides, please.
Great, thank you. Can you all hear me now?
Yeah, all good. Yeah.
Apologies, there was some issue with the the audio there from St. James's.
No problem.
I'll share the screen now.
We can share the slides. We have them in the background if you need them, Rob. There we are. Yeah, all good.
Great. So thanks everybody for the opportunity to talk at this study day. The first 2 talks were I found very interesting and informative, and a lot to learn from them. I'm going to talk briefly on our Irish National Falls Audit. So I suppose firstly, in terms of context, so why are falls important? So this is data from our TILDA study, which is a nationally representative study of older people in Ireland, and basically just shows the burden of falls currently in Ireland, where 1 in 8 older people fall every year. And that's a fall that is bad enough to require medical attention. So that could be with their general practitioner or elsewhere, but 1 in 8 have a fall that requires medical attention. 1 in 16 have a fall that requires attendance at an emergency department. And then 1 in 33 older people have a fall that leads to a fracture. So as you can see already, falls are very prevalent. They're a really key driver of healthcare utilization, and that's at the moment. In the context of Ireland's aging population, the burden of falls is likely to increase really significantly in the next, in the coming decades. And this is the impact of falls on the individual. So an older person who has an unexplained fall, which is a fall where it's not due to a trip or a slip, they just end up on the floor, and it's not really clear why. Over the next 4 years, they have tripled the risk of more falls and more emergency department attendances and more hospital admissions. They've almost 3 times the risk of an injury related to their fall, so whether that's a soft tissue injury or something more serious. They've doubled the risk of a fracture. They've 3.5 times the higher risk of a hip fracture, with all the really, significant risk of morbidity or mortality associated with that. And despite that, we know that specialist multidisciplinary care for patients who have falls reduces the risk of further falls and reduces the risk of this kind of domino effect of adverse health outcomes. This is data again from Tilda, just showing, reinforcing what we've said already about the burden of falls, just showing really how prevalent they are. This is divided up by the regional health areas that care is now divided into, and just shows, I suppose, broadly how many people in Ireland are falling, require medical attention, and are presented to emergency departments, but also looks at the number of falls clinics or dedicated falls clinics nationally. And this was, I suppose, the key thing that drove us to push for a falls audit. So when we look at the relative lack of structured, dedicated falls clinics for patients compared to the sheer numbers of older people who are falling and require this specialist input, it's really stark. So there is unmet need in terms of falls in Ireland. We've no, unlike say stroke or dementia, which are the other kind of real common kind of problems of later life, we've no dedicated falls strategy or falls program currently in Ireland. Care is fairly fragmented. In our unit in St. James's, in the falls unit, about half our referrals come from outside catchment because patients can't access specialist care locally. And falls care is defined quite poorly, so we don't really know at the moment who sees patients who fall. We really don't know who sees younger patients, or how many really dedicated falls patients, how many patients are seen in dedicated falls clinics, or what the referral pathways are. So we hope that the Irish National Falls Audit will address this. It was a audit that's been co-funded by the Royal City Dublin Hospital Trust and the National Centre for Clinical Audit. And essentially we'll look at three broad areas of falls care. So we look at the organisation of falls care. So we look at 26 acute hospital sites, sites with an emergency department around the country. And we look at the number of falls clinics that they have, whether they have falls committees, what kind of pathways are in place for falls training in our organisational audit. We'll do a falls census where we look at the number of patients who are presented to each of these sites with falls and the numbers of patients who fall while they're in hospital, which is another really important problem currently in Ireland. And then we'll look directly at the care patients with falls received by doing a case note audit for patients who were admitted to each of these 26 sites. We are using the World Falls Guidelines, some guidelines from NICE, some guidelines from European Society of Cardiology and from the HSE themselves. We've come up with 10 adapted standards which we feel, I suppose, direct appropriate falls care for all patients, but particularly for older patients. So this includes that, patients should have access to a dedicated clinic, that patients should have access to a falls unit, maybe not in each hospital, but in each region. That patients should be able to, that a falls unit should include a multidisciplinary team that's appropriately staffed, that each hospital should have a dedicated falls prevention committee or group that's led by a senior clinician with an interest in falls, that all sites should screen for the risk of falls, and that all sites should have structured programs for both prevention of falls and training for staff regarding falls. To date, we've had really good engagement across the country. So we have recruited an audit team in each of the 26 acute hospitals involved in the audit. We have an average of 3 clinicians in each site who have taken on that work and are very enthusiastic about it. The breakdown is reflective, I suppose, of the breakdown in terms of clinicians that care for people with falls, and that we have quite a high representation from nursing staff and medical staff, but also from health and social care practitioners. And we have 16 consultants involved as well, which is good, showing the kind of seniority in each of the sites. We have been lucky enough to be able to develop a clinical audit tool for collection of our data with Meg IT, and that's now in place and fully functional, and is a really nice, clean, effective method for collecting data, and feedback has been really good from each of the sites in terms of use of the tool so far. And essentially by the end of our audit, and we're in the middle of phase 2 of the 3 phases at the moment, by the end of the audit, we'll be able to answer questions like how many patients actually present to the acute hospital with falls on a given day in Ireland, and how many people fall while they're in hospital, what proportion of the patients who fall can access the specialist care that has been shown to reduce the risk of further falls, and whether there are geographical inequalities in terms of access to specialist falls care. We'd also know if patients are admitted with falls, how they're managed. So do they have the appropriate kind of comprehensive geriatric assessment that's been recommended? Are there medications stopped? Medications that are known to cause falls, are they stopped? Do these patients fall again, or do they manage to avoid any further falls? Do they get a diagnosis for why they fell? As I said, we're still in the relatively early stages of data collection, but we have some initial results. So in terms of falls activity, our data today has shown that there was over 26,000 admissions due to a fall in 2023 alone. That's over 300,000 bed days in the acute hospitals were related to falls. So that's the most common reason somebody would be in a hospital bed is in Ireland is related to a fall. Over half of those bed days were dedicated to patients who are aged 80 years or above. And the average length of stay for a patient who is admitted to a hospital in Ireland after a fall is 12 days. So you can just see really, I suppose, how prevalent falls are within our acute hospitals, and how, if we can sort out falls care, the impact it may have in terms, for the individual and also for the healthcare system as a whole in terms of bed capacity. We have also found that there are relatively reflecting prior research that demonstrated earlier, that there are relatively few falls clinics currently in Ireland. So there's only 9 of the 24 sites have a dedicated falls clinic. There's a total of only 15 clinics per week in Ireland dedicated to falls, and that over half of these clinics see 5 patients or less. So the vast majority of patients with falls are not seen in a dedicated falls clinic. And a lot of 7 of the 24 sites direct patients with falls to general medical clinics rather than specialist clinics. In terms of falls dedicated staff, only 5 of the sites have a dedicated falls prevention nurse. And there are very few that have, for example, an advanced nurse practitioner or an occupational therapist or a physiotherapist who's dedicated specifically to working with falls. And again, very few also have a dedicated falls counsel service who would see patients specifically with falls after their admission. So that's all I have to present. It's very brief. And as I said, we're still at an earlier stage than some of the other audits who have presented. Thanks a million for your attention. I'd just like to thank Tom Cloney, Karen Reynolds, Annette Cotter, who are also, and of course Nigel, who are also part of the work so far, and the rest of the wider group working group for the falls audit.
Brilliant. Thank you so much, Rob. That's been really insightful. And as you said, it's a journey. And I think what we saw this afternoon is, each of these audits are at a different stage of the clinical audit cycle in true clinical audit genre. So in the interest of time, it's just hitting 1 o'clock. I know we had some ICT challenges throughout. So if it's okay, we might take 1 or 2 quick questions, just maybe for each of the audits, if that's okay. So I know Margaret, on behalf of the team, has just been keeping an eye on the chat box and the QA session, and I know there's perhaps 1 or 2 questions has come in. So Mags, maybe if you just would like to choose a question, I'll let you choose which one there, if that's okay.
Yeah, well, I've got one here for the in-hospital cardiac arrest team, if they're still with us.
Yeah.
And just looking at like what would have been some of the early challenges or insights in establishing the national audit, particularly around standardising data collection around hospitals. Ali, Nigel.
Thanks, Mike. So the big challenge for us compared to OCAR, and I suppose we've talked about AI, is we don't have a national electronic patient record. So that's a huge challenge for any audit. And I think it's really important as this exciting project evolves going forwards in the coming years, and we see it rolled out. We have an obligation as auditors, as people driving quality improvement, that we need to engage with this so that we have systems in place as this rolls out to be able to collect this data and make it more automated and make it user friendly, and so that it doesn't delay our healthcare providers in doing their work, but at the same time allows us to be able to drive meaningful quality improvement. So not having an in-EPR is a huge challenge. Having separate, we talked about DPIAs. We can certainly sympathise with Nuala and Rob in relation to that. The amount of time that goes into GDPR, especially when you're dealing with data in the UK, you're dealing with separate legislation, UK legislation, Irish legislation. Which one should our DPIA be covering? It's a huge headache, and a lot of us didn't have a huge amount of experience with regards to that, and it was trying to find who is the person in your region that can help. For us, I have to give huge credit to our regional QPS lead, Miss Sinead Brennan. She's just been such a driver and enabler of this project for us. And if we didn't have the answer, she always helped us to find the right person. And I think a massive piece for that was having the support of a regional directorate, and to have that leadership piece that could help us with regards to engaging with the appropriate services. But I suppose engaging as a region for us, we really learned that we actually all had the same problems, and it was by sharing the solutions that we found on one site was really, really helpful. And even just having a quarterly meeting where we just touch base on a forum like this gave us an opportunity to be able to put faces to names and to be able to share ideas and resources.
Great.
Brilliant.
Yeah. Very well said. I might just, in the interest of time, hand you over there to our Assistant National Director here in the NCCA, Magella Daly, who might maybe, I'm sure, has a question or two, and maybe just wrap up with some of the common themes. And I know we've had a really deep dive, but I think certainly from the messaging, I think we've heard loud and clear today, is this is real clinical audit in action, and not just clinical audit. I think for all of us, we're beginning to see, yes, it's one thing getting the audit off the ground, getting it to go live, but what we're hearing and seeing from all of your Trojan work is this is now QI in action, because you're actually speaking in QI terms, you're moving to that space, even though the audits may not be complete. And yes, as with all audits, there will be challenges. So, that takes huge leadership individually. So we just wish to acknowledge that. So I'll hand over there to Magella, who maybe might have a question, and we'll do the wrap up.
Thanks very much, Karen. No, I won't bring any questions to the table in the interest of time. I just want to conclude by saying, look, really well done, huge learning. I'm just sorry that we're out of time. I think we could have easily spent another hour having discussions and Q&A around this, because it's fantastic learning from all of this. I suppose the standout one for me was the onion that Nuala and Karen put up on their slide. I think that's what everybody discovers when they get into the space of conducting clinical audits. There's just so many layers to it, but it can be picked off bit by bit. There's a systematic approach to undertaking the audit, and if you follow the audit cycle and follow that systematic approach, you will get through that onion. But key learning for me certainly has been the leadership from all the leads here on the presentations today, but getting that buy-in across 27 hospitals for local participants to be inputting their data is just fantastic and cannot be underestimated in light of the current pressures that the system is under at the moment. So just want to congratulate you, say really well done, and really looking forward to the conclusions and to the findings in due course. And I suppose if there are other questions, if you could direct them into the NCCA email address, we'd be happy to signpost them then out to the various teams that have presented today. And I just want to thank Karen, Mags and Connor in the background, who've been doing huge work around organising the Lightning session talks here today. So thank you so much, and enjoy the rest of Clinical Audit Awareness Week.
Great. Thank you so much, Pagella, and everybody for joining. So yeah, so we let you go off and enjoy your lunch, and we'll speak to some of you tomorrow.
Okay,
Great.
thank
Thanks
you.
again,
Bye-bye.
everybody.
Thanks
Thank
all.
you. Bye-bye.
Bye.